So thank you, Dr. Shubangi, for including me and AIOS APO for the opportunity. I'll be speaking on something which I have actually never spoken before. In fact, when this topic was given to me, I was like, how am I going to present this? And well, fortunately or otherwise, I had to work on this presentation, so I don't know how good or bad it is. It's not a recycled, revised with a background change. So first time I'll be presenting, so let's see how it goes. I have, of course, no financial interest to disclose, but I always keep hoping I would sometime in strabismology. Uh, so vertical deviations for paralytic strabismus, of course, I'll try and keep it limited to key things that we are looking at the third and the fourth nerve. In the sixth nerve palsy, you rarely have significant vertical unless you have another muscle affected, or of course, there is an inferior oblique overaction, which may sometimes cause a little bit of vertical, but more often than not, we get to learn that significant inferior oblique overaction after you've done the horizontal correction, because sometimes it's difficult to pick up, but you can pick up a V, and we have seen V patterns existing in sixth nerve palsy with and without inferior oblique overaction, so you need to realize that, but maybe that for some other day. Third nerve palsy, the eye is, for a complete third nerve palsy, the eye is down and out, which is, as we've been discussing, a major challenge when we are trying to manage third nerve palsy. So what are our options when we're looking at something like this? We have a recess resect procedure with shift, so we could upshift both the recessed and the resected muscle. We have the option of globe fixation of the medial orbit using non-absorbable sutures. I'll just show you. It does correct a little bit of vertical, but there are a little bit of modifications you can do. And of course, the nasal transposition of the split lateral rectus, which is now a very, very popular procedure. So we'll just look at the options we have and how we managed. So this was an 18-year-old male with left third nerve palsy. You can see that there was a very modest amount of hypotropia, about 10 prisms. So we did a recess resect procedure with an upshift. So you can see you got good vertical correction. So about our experience is about 10 to 15 prisms depending upon the amount of, again, the resected muscle is the one that is actually pulling up things, amount of effect you are going to get based on the amount of resection you are doing and the upshifting with that. And of course, this is useful if you have good medial rectus function. Of course, otherwise this kind of a procedure would not be useful. If you have, again, a good large third nerve palsy with significant with modest hypotropia, one of the surgical options for third nerve would be a periosteal, medial wall periosteal fixation. Usually that is very good for horizontal corrections, and we can correct a very, very large angle with medial wall periosteal fixation. And in fact, it's a kind of fail-safe surgery, I feel. We've gone in and done it for all kinds of failed third nerve palsy surgeries, including a failed medial rectus periosteal wall fixation. So correcting modest amount of vertical, and this is possible. Can I have a pointer, please? Because you can cluster the sutures a little, but you don't have too much of a space on the medial wall periosteum. But the other option is that instead of passing the sutures on either side of the medial rectus, you could pass both of them on one side. So if you do that, so if you have hypotropia, if I pass both the sutures, the superior suture also on the inferior side. Yeah, if you pass this suture also inferiorly, then you have a vector that is not only pulling inwards but also pulling upwards. So that's one of the advantages. Again, you can correct a modest amount of vertical when you are doing this. So this is one of them. Again, the other advantage of this procedure is that if this is a fresh surgery you've done and you haven't tackled other muscles, you have actually tackled only one muscle, because I usually combine this with a lateral rectus recession, and you have left the medial rectus completely untouched. There is no vascular damage to that, so you can do a vertical correction also with that. So often when we do not have significant vertical, this was a small hypotropia with the exotropia, and so just the adducting pull helped to keep get a little bit of vertical correction that we required. In this patient, we had a very large exo with a significant hypotropia, and in this we had shifted the sutures so that we could get the upward pull. So this, you can see that some amount of vertical correction is possible. There was an improvement in the hypotropia that was there. So this is, it's of course very fast. We use the pre-caruncular approach so that it's very fast. And for verticals, as I mentioned, you can have both the ties placed below the medial rectus insertion to get an uplift. And of course, a second surgery for vertical recti if the vertical recti are active. Of course, if it's a complete palsy and you don't have good vertical muscles, really recessing does not help. Maybe a bit of plication or resection may help. This is, of course, the much talked about surgery now for management of third nerve palsy. So, split medial transposition of the split lateral rectus. We, of course, as I mentioned, augment it with posterior fixation sutures, and almost always do a posterior tenectomy of the superior oblique so that we can get a good outcome. Not only that, but also help in transposing or getting that superior slip onto the medial side. So Dr. Ankur Shah had given a very wonderful modification in which he had adjusted the this procedure. We just found that with this procedure, when you tie it, you can on adjustables, you can recess it a bit, but if you have an undercorrection, you cannot advance it or get a greater correction. So we cross-fixed it, used a technique that has been described for other surgeries. So in this, what we did was that the transposed slips of the lateral rectus were crossed underneath the medial rectus and left on the short noose adjustable technique. Intraoperatively, you adjust to get an appropriate position, but if there is a little bit of residual post-operatively, you could just open up one side of the short noose and adjust it. So that is one of the ways in which modest vertical deviations along with this large exotropia can be corrected. So in this case, you can see that there was again a little bit of hypotropia, or I may be overestimating it, but again, these adjustments were done intraoperatively so that you are sure of your final position. So again, in this patient, there was definitely hypotropia, and you tightened up the opposite suture or the superior suture in this case and pulled it up a little more so that you could get a vertical along with a horizontal correction. The other thing was if you have a very, very large exo with a significant vertical, like in this case, you can see a significant hypertropia. In this, we transposed the lateral rectus completely from one side. So in this case, the lateral rectus without splitting was transposed from underneath the inferior oblique, inferior rectus, and sutured inferior to the medial rectus. What we realized was that just by doing this one surgery, you get a very, very strong vertical correction, but the horizontal correction leaves a little to be desired. So you probably would either have to club it in the same sitting or possibly in the second sitting, because it's a little unpredictable the amount of horizontal correction you'll get. So in many of these patients, we had to go back in and do a bit of medial rectus plication to get a better result. But again, this was a hypotropia, you can see, and we shifted this lateral rectus from the superior root, from underneath the superior rectus and superior oblique. And again, like I said, you have a great vertical correction, a little short of a great horizontal correction also, and you can kind of use a bit of plication to help you there. So just show you a couple for a single vertical rectus palsy aplasia. We've talked about hypotropias with a monocular elevation deficit. So for, we'll just talk about hypertropias or absence or palsy or trauma to the inferior rectus. You can, of course, do a vertical resect procedure. You can do transposition procedures. One of them we discussed when we were talking about fixation duress for other eye management of monocular elevation deficit. You could do an inferior oblique anterior positioning and use the anti-elevation to help you to get a bit of correction there. You can do an inverse naps or an inferior modified Nishida. So just a couple of patients. This was a patient with an inferior rectus flap tear, a patient with road traffic accident with multiple orbital traumas. Of course, his fractures, he did not have significant vision in the left eye, but you can see the hypertropia and the absence of IR function there. So in this patient, because the hypertropia was modest, we went ahead with just a superior rectus recession. Also, of course, the FDT was moderately positive. But again, just doing a superior rectus recession gave us fairly okay primary gaze alignment, but obviously depression was not there because the inferior rectus was not functioning. So okay procedure for primary gaze alignment. The vision was not great, so we could get away with that. This was a patient who came with a history of blunt trauma to the right eye, and he had this deviation for a decade. He had cataract both eyes. The unaffected eye was operated, but this eye was not because of the position that we'll just see. So this was the position of the eye, very hypertropic and tough to get the cataract surgery done. So the superior rectus was strongly positive for the FDT was strongly positive, and a very mild tuck for the inferior rectus and the medial rectus. So we felt it was a post-traumatic inferior rectus partial avulsion or a flap tear. And so we underwent a superior rectus recession along with an inferior rectus exploration. There was a lot of fibrosis there, so we pulled up and tightened whatever we could observe appeared like the inferior rectus. And of course, he only came for the cataract surgery and not interested in the squint. So we had to do the cataract surgery in the same sitting. So he underwent a cataract surgery. By doing or pulling up whatever we felt was the inferior rectus, you can see some amount of depression has been recovered. So a good primary gaze alignment with some amount of depression has been recovered. This was a patient who had an iatrogenic inferior rectus injury after multiple retinal surgeries. So retinal buckling surgery was done, buckling explant, she developed infection, the buckle was explanted. First stage, she already had undergone a superior rectus recession, and she still had a significant hypertropia, and the lid was recessed, so she wanted some cosmetic improvement. Of course, the vision was poor. You can see a significant scleral thinning where the buckle had pushed and caused necrosis. So the rectus was not available. It was probably operated, and it would have been tough to explore there. You had a risk that the choroid would the sclera would open up, and that would be risky. So we just did a right inferior oblique anterior positioning. I mentioned about using that as an anti-elevation. So you can see it helped in primary gaze to get the eye aligned, and that was the only surgery which actually was theoretically possible in this patient, and we were lucky we got some good result with that. So she was cosmetically okay, and she essentially was looking for her marriage, which I hope had, went on. This was a child with inferior rectus aplasia or palsy, presented with left hypertropia since birth. Again, this child had undergone a superior rectus recession with no significant improvement. You can see that the inferior rectus is kind of falling short of the globe. It was aplasia or absence of development. So in this patient, we planned an inferior oblique anterior positioning and an inferior Nishida on the medial rectus and the lateral rectus. Again, because of the risk, we just did the inferior Nishida. Again, with that, you can see, again, not only are you getting good primary gaze alignment, with the inferior shift of the horizontal recti, you're able to get a down gaze, some improvement in down gaze. Just last, a post-traumatic inferior rectus palsy with residual exotropia, had upward and outward deviation post-trauma, already undergone a recess resect procedure. So we were just wondering what we are going to do. So post-traumatic inferior rectus palsy with residual, the FDT was free. We explored the lateral rectus and the medial rectus. We did an inferior NAPS procedure with posterior fixation. And of course, as we mentioned, for the residual exo, we can plan for managing the other eye. So I think we have, I think time's up, so I won't cover too much on superior oblique. Just talking about inferior oblique weakening procedures that can help us manage the vertical. So I use the anterior positioning to get vertical and use the anterior nasal transposition to get a better correction on the torsion. So I think we'll just stop there. Thank you.
Yeah. Thanks a lot, Rohit. Those wonderful modifications which you have shown for correction of small amount of hypotropia and hypertropia in third nerve palsy were